Welcome to Masterclass number 1 with Dr. Laura Geyer. She is an associate professor of medical education in the College of Medicine at the University of Florida. Before joining the college, she established the health disparities in social academic minor for undergraduate and graduate dietetic programs at UF. This first class introduces the social determinants of health, which we're going to call SDOH, which are social, economic, and environmental conditions that account for up to 50% of the variance in health outcomes between populations. Together, we will explore differences in the social determinants across the 8 states of the Southeast region. Evidence-based health improvement calls for paradigm shift to apply SDOH concepts to individuals and assess them as personal health-related social needs. So we'll turn it over to Laura.
Great. Angie, thank you so much for that kind introduction. And I want our audience to understand that, as the title of our series implies, we're looking at, of course, health outcomes here in Mississippi, your home state, my home state of Florida, and across the Southeast region. So there are 8 states that we're going to start with. Although a lot of our examples, I think, are going to come from Mississippi and from Florida, okay? So we have learning goals that we want to accomplish in this presentation, and I want to start by reminding those who are familiar with the social ecological model of health that we don't exist in a bubble, right? Individuals don't exist in bubbles and populations don't exist alone in society. So we have layers that we have to think about when we're talking about opportunities for health improvement. And I think the social ecological model is the best way to describe those different layers in society that we need to think about. In society, we have to work together. We're not going to go forward by ourselves. The best way to do that is to work with partners, find like-minded partners, and share resources and ideas. So our first learning goal is going to be to examine those interconnected personal, organizational, and structural systems that drive health. Following that by describing the social determinants of health and their role in health outcomes. Then we're going to explore the characteristics of priority populations with unmet health-related social needs. That has a different acronym, HRSN. I'll probably stick with health-related social needs instead of the acronym. They characterize the Southeast region. What we're going to find, I have some charts that I've put together. We're going to find that the 8 states in the Southeast region share a lot of commonalities, some of them very positive, and some of them are areas that need health improvement. And then at the very end, we're going to be closing with proposing actionable, evidence-based solutions for improving health where you live, work, and play. And that is the definition of social determinants of health. It's the environment in which you live, work, and play. So we want people to be able to take this information and think about home as we're going through the discussion here today. So evidence-based. I use the word evidence-based. Medicine is evidence-based. Many of our health professions are evidence-based. And what does that mean? So I like to define terms when I get started so that I make sure that my staff and everyone else is on the same page. And we know that the 2 populations that are going to be participating in the training from these master classes are health professionals that are in practice and students. So what is evidence-based? Well, it's integrating the research, the clinical information, of course, the provider's expertise, and patient values and expectations. So let me talk about programs that are evidence-based. They have pulled data from those 4 different areas in creating the programs and consequently meeting the standards for being an evidence-based program. So when we talk about population health, and earlier in the introduction to the masterclass series, we looked at a model. And it's the model that the Robert Wood Johnson Foundation uses to describe population health. And we know that the social determinants of health play a huge role. But we also, when we talk about population health, have to look at the access to clinical care. We have to talk about people's choices and their lifestyles. We have to look at the decisions that are made in communities and in states, the policies, the practices, the laws, the norms, the political determinants of health. And we use the word political to talk about really politics in its simplest definition, which is how groups that live together in a society need to work together to get stuff done. We just leave stuff very general. So population health is shaped by access then to the social determinants of health, the political determinants of health, and also to healthcare. Individual health is shaped by drilling down into all of those different factors. So when we talk about the social determinants broadly for population health, talking about personal or individual health means we're looking at housing. Do you have access to safe and affordable housing? Do you have reliable transportation? Do you have access to healthy food? We're not talking about do you utilize it, that's a behavior, but just access is really important. And our 8th masterclass talks about access to food and how we can increase it. Masterclass number 6. So when we address those differences in access to the social determinants and their utilization, then we can screen for health-related social needs. And that's really important if we want to move forward, because we know that it's not just listing those social determinants. Do we have housing? But do we have safe housing?
Right.
So those are some of the factors we're going to be drilling down into in this presentation.
That's a wonderful point. When we were doing the state health assessment for Mississippi and we were speaking to focus groups across the state,
Right.
one of the things that was brought up a lot, what we would ask about access to parks to be able to exercise, right? And we're the healthy lifestyle. And one of the things that was brought up was stray dogs. That's a huge problem right in Mississippi. And so if you don't feel safe to go somewhere and walk, then you're not going to do that. Even if the space is there. Like, you can have healthy food in your refrigerator. Right.
If you don't take the time to prepare it, or if you don't know how to prepare it, if you prefer to eat other kinds of food, it's the point, right? So exactly. I have a quote by Dr. Michael Marmot. Why treat people and then send them back to the conditions that made them sick in the first place? That is, to me, such a light bulb kind of comment, because I'm thinking about those providers who are joining us in this master class, who are providing care. And oftentimes we know that when someone's hospitalized, at some point they're well enough, we discharge them home. Or we're sending them right back into the same conditions in which they became sick. So why are we surprised when they are readmitted? Unless something major has taken place to intervene with the social determinants or their health-related social needs, we can expect to see more, of the same in their lives. So we know that health is really influenced by very powerful non-medical factors. It's not access to the doctor and the quality of your doctor's care alone that really dictates your health outcomes. And we describe health outcomes as the longevity and your length of life, your quality of life as well. So quality of life, diagnosis and progression of disease if you become sick, your response to treatment, longevity itself, all of these factors are going to be influenced by health disparities. And, health disparities exist. They're often associated with population characteristics. Healthy People 2030 and 2020 both talk about health disparities. What are they? They're created by factors like minority status in racial and ethnic communities. Perhaps your sexual orientation is a minority orientation. It could be your age that puts you at risk for health disparities, especially if you're very young or 65 and older. I also think about the generation that you belong to, because generations, the baby boomers are a very different generation from the millennials and Gen Z. Your education. How much do you have and what is the quality of that education? Your income. Do you live with disability? What about your first language? Your geographic location. The second master class jumps right in, takes a look at geography in comparing differences in health outcomes and opportunities for health based upon whether you live in a rural area or a more urban setting. And then we can take a look at individual priority populations and get a sense of who they are that we might need to be very aware of screening for health-related social needs. And we need to be from a position of cultural humility and cultural competence, learning how to communicate effectively so that our words don't erect barriers when we try to talk to people. So again, we can think about rural residents. There's a culture, a rural culture, right? It's very different from living in a big city. Pregnant women, they're at special risk. Limited access to food is big. And again, when you have limited economic resources, that makes it difficult to access any of the social determinants of health and utilize them well. And then the social determinants of health are described with a model with 5 different buckets or domains in Healthy People 2030. So it's a little different description than the model that we use, but it looks at education, access, and quality. And when I teach medical students about the social determinants, I always call education the cornerstone. Because, everything in our society, in terms of your opportunity, is built on education. If you want to change your position and your ability to access, education is often the key. The other domain is healthcare access and quality. Neighborhood and built environment. So when you were talking about green space, well, you can have green space, but what if it's not safe green space, right? Our social and community context is really important, and then our economic stability, which is going to be predicted by our education. So when we think about the relationship between the social determinants of health and the health-related social needs, I have a slide that everyone's looking at right now. I'm going to just share a couple of them with you out loud because I know you've been involved with community health improvement. I think these will resonate with you. So again, the social determinant about safe housing, we talked about. But here, we're about this social determinant, access to food. So a screening question for health-related social needs that you might ask would be, and maybe this will be for your next chip, okay? In the last 12 months, did you run out of food? And did you lack having enough money to buy more? Is this often true? Is it sometimes true, or is it never true? So keep it simple for people to respond. Right. Same thing with affordable utilities. A lot of times we think about housing, but we don't think about the utilities. Really important to ask questions about utilities. So that's another health-related social need. Here's a screening question. In the last 12 months, did the electric, water, oil, or gas company threaten to shut off your services? Yes, no, or are they already off? And when they go off, again, often we're talking about families with limited economic resources who don't have the money to pay to have everything turned back on again and then pay the bill. So it's a big problem. In turning to that model, okay, that we're using throughout our series to describe health outcomes, because our goal with this masterclass series is to improve health outcomes across the Southeast region. So in order to do that, we're going to look at the geospatial determinants of health. And that's a new term for a lot of people. It was a new term for me a couple years ago. I met a medical geographer at the University of Florida. And that's how I discovered the geospatial determinants of health. Again, geography with health information combined. That's all that is. So in the model that we're using, we're looking at the state of Mississippi because I'm going to have some questions for you since this is your home state. And then we go into the model that the Robert Wood Johnson Foundation uses to explain population health differences. But added to this, then, the individual categories of health-related social needs. What are some of the items that we can formulate good questions for to drill down into people's lives to see something about the quality of their life so that we can improve it? So I'm looking right now at a map, and it's an image of the state of Mississippi. And if we want to improve health outcomes, what would we look at specifically? Well, the Robert Wood Johnson Foundation has a lot of great information on its website. I don't know if that's something you use often in your work in the community and in the state. I know it's something in my teaching that I use regularly. So when we look at health outcomes, here's how they define health outcomes. How long people live on average in their community. So how long do we live? How much physical and mental health they experience in their community while they are alive. So that's their quality of life. And there are several items listed that you can pull data for. Actually, a lot of this is found in the census if people are interested in looking at their individual states. For example, we can look at whether people think they have a fair or poor health, how many days of a week do they experience that. We can take a look at infant mortality rates as a marker. We can also look at whether people feel like they're experiencing frequent physical distress or mental distress. And there's a color coding that goes along with this picture, this image. I'm going to show it to you so you can see it.
Okay, great. So here is your state of Mississippi.
And everyone else is looking at it too, who's viewing the masterclass. And you can see that as the colors change from orange to very dark green, this is how we identify the counties. The geography marker is county. This is how we identify the counties when compared to the entire United States, not just to Mississippi, but the entire United States, have the lowest and the highest or best health outcomes. All right. So you can see where we are right now. Okay. And I'm going to ask you some questions because everyone else is looking at that. Now you've seen what we're looking at. So you're going to know how to answer these questions I'm going to ask you.
Okay.
So, and I'm going to pose these questions for our audience too.
Okay.
What do you think explains the differences in health outcomes in Mississippi? Let's think about the social determinants of health, okay, that we just talked about. How do these counties differ? So we think some are rural, some are more urban.
Right.
And what do you find in those counties, okay, as well, affecting the length of life and the quality of life? I can tell you that I live in Alachua County in Florida. This is where the University of Florida is housed. Now, when people think of Florida, I think the stereotype is they think of a lot of people speaking Spanish. They think of sunny beaches. What do you think of?
The beach.
And I want you to know that rural North Florida is nothing like that. Nothing like that.
Understand.
We have 12 to 14 counties in the central part of our state, number one, that do not experience direct hits from hurricanes usually. I've been to Alachua County, we've never had one. But these counties are rural. They're not urban. They're not on the coast, and so there is no beach. And they are also not that diverse.
What?
We basically have rural families that have been in those communities for maybe generations. So with that thought in mind, putting on your thinking cap, and everyone who's visiting at this time, putting on their thinking caps, here's a question. Mississippi has 82 counties.
Mm-hmm.
Rankin County was the only county in that dark green color, meaning that compared to all the other counties in the United States, the people in Rankin County have really great health outcomes, longevity and quality of life. Why? Tell me about Rankin County. What's so interesting about Rankin County or different that people who live there would have such a great length of life and quality of life?
So it's growing. Okay. Economically, it's doing very well.
Economic opportunity.
Yes. The education, the schools are very good. They have a great public school system. A lot of people are moving that way. So the population has grown There's constant building. And so when you see houses being built, then you know the economy's doing well.
Right.
And there's lots of businesses popping up. So it's a great area. You can find most anything you want to do. There's a lot of people exercising. They just opened a huge pickleball court that is, that's the thing now. And I said, oh, sure. It's huge in Rankin County. I think it's the only one in the state, maybe.
You'll probably, because we can see from the dark green color, there's something unique taking place in Rankin County. So you talked about economic opportunity. You talked about education. You also talked about infrastructure, okay, with fitness centers and just all kinds of new building and growth where people can socialize and they can exercise and rock, and we know it's safe, right?
Right.
And so we also have opportunities for socialization and for civic involvement.
Right.
And probably have great health care too.
There is great health care there. There's several hospitals that are very nice. There a lot of my doctors actually Rankin County.
So we hit all 5 domains of the social determinants of health in Rankin County, but not in the other counties. So as a state, how does Mississippi want to improve health? I'm going to leave that in your lap because that is the work that you do here at the Mississippi Public Health Institute. And we're going to continue our discussion. So I'm looking right now at a chart, and it has all 8 states as well as the United States. I'm looking at the total population. Total population in the United States has grown to 331.1 million people. So we continue to grow, as a nation. Let's take a look at a couple of individual factors, okay? So I want to call attention to the rural population. Here in the United States, about 1 in 5 people in the U.S. lives in a rural area. Well, what do we find in the Southeast region? Everyone who's looking at this with me right now can see that, oh my goodness, with the exception of Florida, all of those other 7 states are much, much higher in terms of their rural population. And in Masterclass number 2, we talk about what that means to live in a rural community. It's beautiful. You have all kinds of space, but you also have limited access to resources. We can also take a look at this chart and recognize that, oh my goodness, the percent of individuals in the U.S. that are foreign-born, about 14% of the population. We can look across at these other states in the Southeast region and see we have many fewer people that are born abroad. Basically, in the Southeast region, we're talking to people who were born right here in the U.S. We can take a look at the racial identities and see that the majority identify as white or Black. We don't have as many that identify as Asian American or Hispanic.
Okay.
What that means is we don't have the same kind of language diversity. Here in the United States, we speak more than 350 languages.
Wow.
Yeah, we're very diverse. In the state of Florida, and this is one of the questions, what percent of the population speaks a language other than English at home? We call that, what is your first language?
Right.
In the state of Florida, it's about 30%. Let's see, 30.8%. Compared to 1 in 5. So much greater language diversity in the state of Florida. But again, Florida is the anomaly on this chart because in all the other states, it's a much lower percent that speak a language other than English. We can see that we have a higher prevalence of disability also in the Southeast region, which shouldn't be surprising because agriculture is still a way of life. We have much more limited access to healthy food, which contradicts what I just said because agriculture, we're growing a lot of the food right here in the Southeast, but people don't have access depending upon where they live. They may not have transportation, and everybody's not living on a farm.
Right. And they're probably not growing food. They're probably growing cotton or soybean or something that is not a big cash crop in there. Or they're growing chickens like I did that they're sending them off. Right. Yeah, it's big. So we had no people living with food insecurity in the Southeast region. Okay, another chart that I put together, again, comparing all 8 states and
listing the United States as well, kind of as our baseline for comparison. In terms of life expectancy, here in the U.S., on average, we live to be about 77.1 years. That's on average. So, it counts for all the extremes as well. What do you think the life expectancy might be, knowing that people are food insecure, et cetera, is that we find they're living shorter lifespans in the Southeast region, again, with the exception of Florida. But I want you to know that in Florida, we are a very different state because we have so many people that move to Florida after they live their life in another place. So I can't tell you what's happening in Florida. Are those healthy people, probably educated people, and I know they have wealth because of some of the cities that I've lived in, like Sarasota. That's my hometown. I'm living in Gainesville now, but we have a lot of wealth that moves to Florida. So health and wealth go together.
Right.
Housing costs, again, we can take a look at across the Southeast. It's cheaper. Housing is cheaper. People earn less money, but I want you to know that there are opportunities for employment, and the employment rate meets the national standard. So we're equally employed. It's not that we're not working hard or we're not working, but we're earning less money for the work we do when we live in the Southeast region. I'm looking at educational attainment, and as you might imagine, people don't complete high school as frequently, nor do they go on to pursue a bachelor's degree or advanced education when they live in the Southeast. So here are some areas for opportunities for improvement. And then when we look at health behaviors, so we've gone through looking at demographics, like who are you and who is your community, and what kinds of education do you have? Do you live with disability? So we've looked at some of those population characteristics. What kinds of health behaviors are people engaging in? So we can take a look and see that in the nation, about 48% of Americans get their flu vaccination every year. But across the Southeast region, some states are doing pretty well. They're pretty close to the average, but in others, it's much lower. Mammography screening, kind of the same thing. We're less. Smoking, the use of tobacco is much higher in the Southeast region. Masterclass number 9 is going to look at tobacco cessation. Our prevalence of chronic disease like diabetes and obesity are much higher. Dr. Farrow is going to talk about that in his masterclass. And high blood pressure, hypertension, and cardiovascular disease, again, are high. So how do we improve health outcomes? We have to look certainly at the chronic disease that exists. We have to look at our health behaviors. But again, remembering that at least 50% can be influenced by looking at social determinants. That's why this conversation is important. I have a slide that kind of summarizes the information that I just went over, and leave it up for just a second for people to take a look at, remembering that people who are U.S. born have less education as a rule than the rest of the nation, okay? They speak English, so it's not that there's a problem with language when it comes to jobs or employment or opportunity. And they have a lower life expectancy, U.S.-born citizens. So we want to think, maybe a little differently when we put programs together. How can we reach people in the communities that they live in and touch on the values that are important to them? So some of the evidence-based health improvement tools you are very familiar with, and I'm so glad you've joined me for this conversation, because we're going to talk about community health assessments, or CHAs, and health improvement plans, or CHIPs. I know that's where you spend a lot of your time, and you worked on the state's health improvement plan.
Yes, I did.
So for those who aren't familiar with CHAs and CHIPs, and I think the audience that we are addressing with this masterclass series is really important for them to know what CHAs and CHIPs are. In public health, this is a language that you use. But people who are health professionals don't know that nonprofit hospitals are required, as a condition of maintaining their nonprofit status, they are required to conduct a community health assessment every 3 to 5 years.
Right.
And folks, the reason that's important for you to know is that whether you're a student or you're a health professional who is in practice, your nonprofit hospitals in your community have community health assessments that you can pull, that usually these are available online. And the reason you want to take a look at that information is because it gives you valuable insights into the nature of your community. Usually this is done on a countywide basis. So it'll be the nonprofit hospitals in a particular county. What you do with that information, again, required under the Affordable Care Act, and in public health, this is a requirement for accreditation. So the Public Health Accreditation Board and the Affordable Care Act in 2010, it was really a landmark year. That's when both put the requirement for a community health assessment, and then you take that information. You maybe collect additional information from some focus groups, but usually that's part of the assessment process. It's just really finding the themes in the data about your community to put together a plan for health improvement. Well, anything that's going to focus on the social determinants of health or use that as a guideline for organizing the information is going to succeed. Can't help. I mean, it's almost like you can't help yourself. You're going to succeed because 50% of your health outcomes are going to be predicted that way. Consequently, 50% at least or more will be improved using the social determinants of health.
Right. And so with the state health improvement plan or the community health improvement plan, you always are looking at things that you can work with partners. So it's not just what the health department might do or what the hospital do. It's what we can do with education, what we can do with the Small Business Association, what we can do with all the partners to move the needle, the mental health, every bit of it working together, because we can't move the needle alone. And so that is that's what accreditation was about. It's about partnerships. It's about working together to make a difference in our health. And so that's so important.
And that's what this entire masterclass series is about. And the final class, the title is A Call to Action. Okay, Partners for Health, to work across silos, because it's too big of a job to do by yourself. I hope that's good news. I know in many instances, it's very difficult to lay down your identity or to lay down possibly the attention, that you get from being, the lead agency or the one who's doing the work. But the job is too big if we want to improve the health and well-being of people who live in our communities. So, again, learning to work together is a special challenge. But in the times we're living in, the Center for Medicare and Medicaid, the Joint Commission, which is an organization that accredits healthcare organizations, both of those together have united in their call for requiring hospitals, nonprofit hospitals, to screen for health-related social needs. So we are moving in a direction toward health and partnership, which I think is great news.
Yes.
Yeah. So these next couple of slides, just for everyone to know, on these next couple of slides, because I recognize that those who participate in this master class are coming from all 8 states in the Southeast region. Well, not only do we have community health improvement plans for our counties, we also have state health improvement plans for our state. And one of the requirements is that your community health improvement plan fits into the bigger picture of your state's health improvement plan. So your state wouldn't be interested in something that none of the counties are interested in, because how could you work together as a unit, as all the counties in the state, if the state's plan was so different? I thought that the students and providers who are here with us might be interested in looking at their state's health improvement plan in terms of the priority areas that were established. So with every state that I've listed, I've also included the year that their most recent health improvement plan was published. So looking at Alabama, there are 3 priority areas that were published in 2024, so just last year. My state of Florida, we have actually 7 areas, but I've listed on the slides for comparison is only the top 5. And in many instances, the states have fewer than 5 because that's a lot. That's a lot to tackle in a 3 to 5 year period if you want to see any kind of significant improvement. Georgia's most recent plan, published in 2017, Kentucky in 2024, Mississippi in 2022, and North Carolina 2023. There are so many commonalities in these SHIPs. There's a focus on chronic disease. There's a focus on maternal health and well-being. Many are focused on access to food. Improving the social determinants of health, yes, is also listed by many states as a goal in one of their priority areas. We have individual populations like children that are highlighted in some of the states' health improvement plans. South Carolina, for example, published in 2024, and they have a big focus on children. And Tennessee was also published in 2024. So it looks like a lot of us are on the same cycle, about 2024-ish, plus or minus a year, to go into our state and improve health outcomes using the social determinants and focusing on the needs of priority populations. And the way we're going to do that best is by drilling down into those individual health-related social needs. So here's a question for everyone who's joining this class online. Kind of a check of your IQ, your SHIP IQ. So which response is false? The SHIPs that I just described by the end that are described by this master class. Tell me the false statement. Are they developed by research institutions? Are they state health improvement plans? Are they required for health department accreditation? Or are they blueprints for resource distribution? Any of those sound false to you, Angie?
What was the first one?
Developed by research institutions?
So some of that is actually true because some of the states will actually, they'll get a marketing group or someone to do their state health assessment or community health assessment and community health improvement plan. They will work alongside. But so that actually is true.
Well, I'm going to have to change my answer, Katie, that they still have to work with the community. So it's not like they're doing something strictly online, let's hope, or the board of, Bruce,
Now, that is not at all the way the ones I had been a part of. I am a site visitor for FAB, and I've worked with the State Department of Health in Mississippi. So no, we went out into the communities. So yes, it is an improvement plan for the communities, and it's done by the communities for the communities. We listen to them. We hear what they have to say.
Right.
The data may tell us one thing, but if they're saying there is another problem, then we want to work on what they want us to work.
Exactly. So we could say that who actually assembles the document, okay, it could be an external group. Yeah, that would be perfect. Yeah. But the purpose, it is not supposed to be a research document. It is supposed to be a living document with information from the community.
Yeah, absolutely.
So let's take a look at evidence-based solutions. Okay, so define evidence-based solutions. Okay, at the very beginning here, we're applying research. So research is important, but clinical expertise is also important. We want to look at patient values and their preference. So we want to hear from people who are receiving and participating in healthcare. Again, it has to be focused on the people.
Right.
So there are a couple of websites that I use frequently for the health improvement work that I do in my community. I am a faculty member, so I do teach and I engage in research, but my research isn't, in another country, which we need to do research in other countries. But the most important part of research to me is being able to improve health in my own backyard. Because in little North Central Florida, honestly, there are many conditions, many states and parts of the state where It's almost like being in a third world country when you realize the limited access and the lower economics of some people. So Community Commons is a site that I visit frequently. This site is managed by the Institute for People, Place, and Possibility. I love that possibility. I love what's possible, right? And this is a nonprofit organization. They are working to create healthy, equitable, sustainable communities. All words that resonate with me in my work and with you, I know as well. So they have toolkits, they have resources, they have data, they had mapping tools. You want to map something? I know you're mapping food. Mapping tools, they have stories. Our third masterclass, telling stories as advocacy. So you can go this site and get a lot of information. They have 12 different categories of information they provide resources for. So plethora of information. Another site that I use is the Center for Healthcare Strategies. This is another nonprofit, nonpartisan organization dedicated to strengthening the U.S. healthcare system. So this is a site that focuses on the system. That's hard to find. And they share best practices. So they, again, have about 12 or 15 focus areas. Some of those include adults with complex health and social needs. When you're providing healthcare, these patients can be very difficult to manage because their needs are in so many areas. And frequently, you have to address those social and economic needs first before you can ever make a dent in their health, right? Another category, cross-sector partnerships. How do we work together and work across, right, to make things happen? Delivery systems and payment reform. So you find some really different categories on this website when you think about and compare to other sites. A site that I'm very familiar with and that I use regularly is the Robert Wood Johnson Foundation. Do you go to that site in the work that you do?
I do. And you use it.
Right. So this is a site that has just volumes, honestly, just volumes of information. And so I've highlighted for the students who are joining us and for health professionals who may not engage with their community as often. That's the value that I find with the Robert Wood Johnson Foundation's data. They are evidence-based and they are focused on the concerns of physicians and nurses and professionals in the context of community.
Right.
So they have a compendium of valid, reliable, and unbiased sources of data. Oh my goodness, where can you go to find information that you can trust? Robert Wood Johnson Foundation provides that information for you. They have a number of data and databases, sources of data and databases that you can use to explore health in your county. Some of their data is available on by zip code. I don't think they have any by census tract. But again, if you can drill down to the zip code level, you've done a lot right there. With regard to the evidence-based strategies, and for those of us who write grants, I know you spend time writing grants. If you can call attention to the fact that components of the program you want to implement is evidence-based, that you're using an evidence-based strategy, that's going to speak volumes to funders, right?
Right.
So there are 12 topics that Robert Wood Johnson Foundation will list for evidence rating. So it could be scientifically supported. There could be some evidence, expert opinion, could be insufficient evidence. Those would be the things you wouldn't want to put in your grant. There could be mixed evidence, and there could be evidence of ineffectiveness, another category to avoid. But isn't it good to know that there are some strategies that are published, and when investigated, we have found they're ineffective. Just because they're published doesn't mean they're ideas that worked. And then we have a variety of topics also that you can explore. So you can take a look at tobacco use. You can take a look at air, water, and land. what's the quality? You can take a look at civic and community resources. So again, Robert Wood Johnson Foundation, terrific source of information. And then when we're designing healthy communities. So we have 2 of our master classes that are provided by nonprofit organizations with evidence-based solutions. One of them is Mom Me, looking at maternal mental well-being, and the other is Hearty Helpings, looking at food access. So for those who are joining online, they can take a look at this example, and I'll share it with you because I think, Angie, you'll find it very interesting. So we can take a look at the evidence base for Mom Me, and this is what you're going to find on Robert Wood Johnson's website. So if we explore culturally adapted health care, because it's a those cultural competence is factored into the activities and the approach. Here's the description of what culturally adapted healthcare looks like. And what kind of evidence do we have that paying attention to cultural differences makes a difference? Does it matter? Well, let's take a look at this evidence rate. It is scientifically supported. There was not a question about paying attention to culture as that's who you are. Hi. Paying attention to that is really important. And in addition to being scientifically supported, we can expect to see a number of benefits from approaching health care, and health improvement through the lens of culture. Absolutely. So when you think about grants that you write, wouldn't this be important information to point to? And don't you think that this would give you more points when the reviewers are looking at your grant?
Absolutely. Absolutely. That's what they're looking for. They're looking for collaboration. They're looking for those things that have been proven to work.
Right.
And like they're not wanting us to reinvent the wheel.
Exactly. So again, for all of us who are involved with health improvement, there are a variety of resources available to help us, do a better job, find collaborators, find like-minded persons. And when we get to our 10th masterclass, I'm going to share a model of what we've been doing in Alachua County. We've been doing this since 2013 as a result of our 2012 CHIP, which was our first accreditation process for our health department. So I'm going to recap right now and close our masterclass. I'm going to start by saying that the social ecological model of health does provide a cornerstone for us in this masterclass series and in this discussion today about the social determinants of health. And it offers a practice-based theoretical framework for viewing the social determinants of health and their influence on health outcomes in the context of those layers, okay? Because they are personal, they are interpersonal, organizational, and they're also structural. So the next 8 master classes. So here's our starting point. We've got now 8 in between that make the filling of the sandwich, and then we've got the bread at the end that'll be the call to action. But these 8 master classes now that we're going to follow through and examine, they do follow the Robert Wood Johnson Foundation's model of population health with the added supplement of the health-related social needs so that we can look at improving individual health. And then the final master class is capstone, and it's going to pull everything together. It's going to unite the series content. I hope it's going to challenge people. I love to challenge people and leave them feeling a little bit uneasy after a presentation because here's something I could do and I can't wait to go get it done. So I'm a little uneasy, a little antsy until I can put that into motion. But I'm hoping everyone will be challenged to apply their new learning using evidence-based solutions in their own communities to improve health. And that's what I have for this group today.
Thank you, Laura. That was so enlightening. I love talking about the social determinants of health. I love talking about community health assessments and talking to the communities and improving the community life. And so this has been very helpful. It's a wonderful kickoff to this to the modules, and I'm so excited about seeing the rest of them.
I'm excited to see the rest of it put together. And I think here's what I'll share with our group.
Okay.
So this class has ended. I hope that you're going to join us for our second master class. We're going to be examining real health, and Ryan Kelly is going to help us do that. And right now, we can tell you that class is dismissed.